The opinions and statements made by the guests of the Success in Practice podcast are their own, and I do not endorse or accept responsibility for their positions. Any information given by myself or the guests is educational in intention and not to be taken as medical advice. If you choose to act on the content involved in the podcast, you do so at your own risk. Welcome to the Success in Practice podcast. I'm joined today by Heath Williams. Heath is an osteopath currently operating and practicing at Principle Four Osteopathy in Melbourne, Victoria. He's been a registered osteopath since 2004 after graduating from Vic Uni in 2003. He was able to travel and work in various countries across Europe and was able to work and teach in the UK in 2006. He taught at both the British and London schools of osteopathy. He returned to Melbourne in 2009, where he completed tertiary qualifications in Occupational Health and Safety and Work Health and Safety. In 2010, he worked as an associate whilst establishing Principle Four Osteopathy. Heath works collaboratively with his business partner, who happens to be a physiotherapist, offering courses in both rehabilitation and occupational health and safety, as they both continue to grow their practice. Heath is titled by Osteopathy Australia as an Occupational Health Osteopath, and he's married with two children who seem to be as active as he was growing up, by what he says to me. And he continues to invest in his own health and enjoys kicking the footy with the kids. And by footy, I'm assuming you mean the red Sharon ball, Heath, is that correct?
Of course, yes. That's the only football here in Victoria. So, yeah.
Heath, welcome to the podcast, mate. I appreciate you taking the time, especially out of your busy day, to kind of do this.
No worries at all. Thanks for having me, Sammy. I look forward to having a nice chat.
That's all right, mate. Look, I think today it's best that we kind of have a chat about maybe your occupational health and safety experience so far and what you've been doing in that, because I think that's a little bit off the beaten track to what most osteopaths will be used to. And I think also to have a chat about the rehab space and what you're doing there and how you practice in those settings. I'd like to take your experience about, especially working in the UK. I think that's something to explore, and what it was like applying kind of the Australian twist, I guess, or the Australian version of osteopathy in the UK. And maybe some insights about your own practice and what you're currently doing and what you're working on at the moment. Look, you've used osteopathy to transition into occupational health and safety, and I'd like to understand the genesis of that and the journey to kind of get there. And now you're currently involved, I think, with Osteopathy Australia. So maybe getting your input on the landscape of what's going on with osteopathy in this country, and your input there would be of interest to some of the listeners. So is there anything else that you want to address or something you'd like to talk about?
That sounds like plenty, to be honest with you. So, yeah, happy to chat about anything.
Well, it seems like we're both pretty direct and straight to the point. So I think we'll make this, at least people won't have any fluff in this conversation. I don't think there'll be lots of fluff today. So
yeah.
Anyway, let's get into it. You grew up in country Victoria with a strong sporting background that at the very least gave you an appreciation for performance physiology, let's put it that way. How did that morph into you becoming an osteopath? Tell us about that journey.
Yeah, no worries. So, look, I grew up in a small town, Kyabram, 6,000 people, which is located northern east of Victoria, somewhat between Echuca and Shepparton. And so, obviously, every spare minute was typically spent outside. Growing up as a primary school child and then into secondary school, and a large part of being within that community was working, sort of playing sports. And for me, that was Aussie rules football and tennis. And so my particular interest at school really sort of was wrapped up around physical education, biology, chemistry, those types of subjects. And as I was going through high school, I had a few injuries myself, playing sport. In terms of, say, exposure to osteopathy, that was non-existent. And I didn't really actually know much about osteopathy until I got to year 12 and chatted to my careers educator. However, my interest in physiology, biomechanics, the human structure, training and performance was sort of all wrapped up into that stuff. And so as I approached that sort of year 11 and 12 sort of phase of schooling, I was very much sort of wanting to identify what can I do that's going to sort of obviously have me working with people, which I love, but also spending time understanding and working around that sort of performance and the body and mechanics and that sort of stuff. So the careers educator said, well, why don't you look at osteopathy? I also had physiotherapy, chiropractic down, OT, speech path, so a real mix in that allied health space. And upon graduating from high school, I was offered a space at Vic Uni, and that was very appealing. And so I sort of pursued osteopathy thereafter. So to be honest with you, though, my appreciation and understanding of osteopathy was zero at that point. And it wasn't really until, I suppose, the first day of university, turning up into Melbourne there, was I like, oh, wow, this is what this is about, and that sort of stuff. So by chance, if more than anything, I found myself in osteo, probably much like a lot of people in regional Victoria, and that'd be probably throughout Australia, sort of 20 years ago, where sort of osteopaths were not really sort of, you know, they weren't present in those regional areas and that sort of stuff.
Yeah, right. Look, I can empathise with you there, mate. I was tricked into it by my careers advisor. He told me he was putting me into physiotherapy.
Yep, nice one.
Yeah, I'm sitting there waiting for my acceptance to come through, and I'm like, I haven't got anything. It's like, you know, mid-January now, and the university's about to start, and so I get where you're coming from, and yeah, I turned up the first day not knowing what to expect, but I guess you know, once you're there, you don't look back. It's been great. I want to ask you a question around. You kind of answered that you chose Victoria University because it was a position offered to you. I'm not hugely familiar with the landscape in Victoria, and I want to ask you, and I don't ask this in a derogatory way or in a way to kind of create conflict, but I really want to know what would make someone choose either VU or RMIT. What are there differences I'm not aware of? You know, what would make somebody? Is there like a Australia versus New Zealand rivalry going on there? What's going on?
Hello everyone, I'd like to take a quick moment to thank everyone for watching and listening to the podcast. If you have received value from this episode, the kindest thing you can do for me is to like, share, follow and subscribe to the channel on whichever platform that you are listening on. If any of the conversations have resonated with you and you feel that I can help elevate your practice, you can find me at successinpractice.net. That is, the Success in Practice program can be found at successinpractice.net. The Success in Practice program is the signature program that takes a practitioner who may be struggling with retaining patients. They may not be certain about building effective treatment strategies, and they may feel somewhat anxious and doubtful about what they are going to do with a patient. And they are not really accelerating in the real world of private practice. It takes this practitioner and it turns their careers right around to the point where the patients have an effective diagnosis and a real treatment plan that they can take home. Patients are happy to book in multiple sessions with you and they are confident about your abilities. And more importantly, you now have direction and are confident about your own abilities. The program streamlines how you operate as a practitioner. Guys, you should have been taught this at university, but you weren't. You may have been practicing for the last few years thinking there has to be a better way. There has to be a more effective way of engaging with patients and getting them results. Well, there is. And this is what the program delivers. Go to successinpractice.net and check out the options available to you. See where I can help you easily grow your patient list and finally earn the rewarding income that you deserve. For all the information on how you can reach me personally, check out the show notes. Also in the show notes, you'll find a link to the chat transcripts from these podcasts. These are valuable and a wealth of information. I really hope that you're enjoying the podcast. Guys, leave a comment if there's any questions on this episode, and please, don't forget to like, share, follow, and subscribe to the channel. Now, back to the show.
I suppose so. Like, if I speak from my own experience, back at that particular time, it was literally around. I'd applied at both. I got offered a spot at VU, so that was pretty simple. I got into one. I didn't get into the other. But outside of that, it was very much about, well, where's the location of that university relative to what's going to be easy for a country kid coming to Melbourne and that sort of stuff. However, if we speak to, say, current times, and again, I can only speak to my experience doing some clinical work and sessional teaching and lecturing at BU. You've now got BU being a 4.5-year course, and it is what they call block mode, where students go through 4-week blocks of learning compared to the traditional semester model, which is first semester, second semester at university. So that's at RMIT. So that's probably 2 distinct differences now between the universities here. And then I suppose other factors that might feed into that are probably going to be, again, outside those logistical components to it, and acceptance into those courses, might be pretty much based on the subjective feedback that people are going to get by talking to someone who'd been somewhere. So most of the students that I would teach have probably, that are at Vic Uni, have probably been influenced by somebody who went to Vic Uni and that sort of stuff. So therefore, I reckon that's often a real driver for that decision-making process. In terms of the academic teaching differences, I can't speak to both just because I don't know the absolute ins and outs of RMIT, but there will no doubt be differences in terms of, I suppose, the focus points of what's being taught away from the clinical science components and that sort of stuff.
Yeah. Okay. Well, that sheds some light on it, and I think it'll be good to maybe get a perspective from somebody who's been teaching at RMIT. I think that'll help. I just don't understand what would make, and it's like I said, it's I don't. I'm not trying to create any kind of conflict there, but I just want to really learn about it.
Yeah, I think the block mode now would be a heavy decider around that.
Yeah. So do you find? I mean, you're in Melbourne, and are you either employing or contracting or having new grads come to your clinic? Have you had new graduates come through to your clinic from both universities?
So in terms of those practitioners that have contracted within our organisations, they've in the clinical setting, they've all been from VU. Right. However, if I think about the Occ Health Services, we've got a mix there. However, though, we get students coming in and doing observations regularly from both RMIT and VU, and I suppose.
Can you shed some light there, seeing the students? Do you notice differences? Do you notice maybe philosophical differences?
Yeah, slightly. I suppose probably some of the main differences that I would take, and again, you're only getting a biased view of those people that have sourcing out our clinic because they're coming there for a particular reason. So they've got an interest in exercise rehab, S&C sort of work, plus the manual therapy side of it. Traditionally speaking, I would say that RMIT probably had a bit more of a focus around your manual therapy skill set. However, I can't speak to anything post-COVID.
Okay. Yeah. COVID was kind of a big, fork in the road there for a lot of the ways that students were getting taught. So hopefully things can go back to how they were. Look, who were your mentors early on in your osteopathic career? What did you feel that they gave you that was so valuable?
I suppose going through university days, a couple of mentors were some of our clinical supervisors who we obviously spent a lot of time with in clinic and under the guidance of patients. And typically they were like Brendan Majew's one of those osteopaths who was probably 5-6 years ahead of us, being one of the first cohort of graduates from there. And then obviously early on, and I'd probably say to this absolute day, my mentors are still the same group of people that I went through university with. So in terms of, say, I've got a good 5 or 6 osteopaths that we still are constantly in contact, and we're learning, I suppose, arguing, we're debating, we're sort of helping each other, be it around the clinical stuff, but and then also around the business side of stuff. So that would be the likes of Shane Peace, Matthew Harris, Ben McChesney, a whole group of osteopaths that were all from that sort of era. And then obviously I spent the first 15 months of my career working up back where I grew up, and also working a couple of days in Melbourne for Brendan Majew. And after that, I moved overseas and lived in Sweden for a year. And then following that, we moved to the UK, which is probably where a lot more mentors came about. And I suppose there was a range of osteopaths there that acted as mentors through that developmental phase of my career. And again, I'd probably say that in every stage of my career, there's always been groups of individuals who are there probably mentoring and advising and providing advice at different phases. Some stay throughout the process, and then some come for a few years. And then obviously, you know, there's probably just less contact there with some of those individuals.
Yeah, okay. So you mentioned being in the UK and that some of your mentors came in around that time. How was that experience there? Can you compare and contrast kind of osteopathy here versus what's going on in the UK? What were some of the challenges for you as an Aussie osteo in terms of the way that you worked? I mean, obviously, you know, Aussies cop a hard time in the UK just in general, but you know, in the way that you worked, were there any challenges there to overcome?
Yeah, look, I suppose if I focus on the positives and the strengths of being an osteopath in the UK as an Australian trained osteopath, we had what I would call a very biomechanical structural model and approach to working with clients. And the perception of us as Aussie trained osteopaths that we had relatively decent manual therapy skills. We had good exercise and rehab and conditioning sort of skills and patient management skills and orthopedic assessment skills and clinical diagnosis. So that was probably the perception of what we could bring to that space. But obviously osteopathy over there is much more broad, and you've got obviously with so many different universities and so many different approaches and philosophies of ways of working, it was a bit of an eye-opener to an Australian trained osteopath. So obviously if you spend time with the Classical Institute of Osteopaths, then you're going to have a very classical approach to treatment. Then you could spend time, say, at the BSO back then, which is much more, say, structural. If you spend time at the ESO, the European School of Osteopaths, you're going to have osteopaths that will probably a lot more visceral approach to treatment and that sort of stuff. So for us being in Australia, it was very much either you're a structural osteopath, we'd identify as, or you were sort of obviously a more indirect practitioner here in Australia. Over there, it was obviously you had those approaches and a lot more. So spending time there really opened up, I suppose, the eyes to understanding and getting a glimpse of, well, okay, there's more to osteopathy than just what we have here. And so therefore, we really need to seek out the opportunities to learn and spend time with these different people, because they're all going to be great in some way. So what is it that's great about those people and those approaches that I might find myself wanting to sort of, you know, learn from and integrate into practice and that sort of stuff?
Yeah, right. Okay, well, I guess that's something to think about in terms of, you know, taking on new skill sets, but less than more so than skill sets, but it's more the mindset, right? Like new approaches in terms of how you think, and that's really the essence of osteopathy. It's about how we think, not really about what we do so much, because all the information is available there for every type of therapist. But I think how we think is usually what makes us unique. Yeah. So having a cohort of people that you can be around that think a little bit differently, but they're still osteopaths, really would broaden your horizon. So I can appreciate that. Mate, tell us about your clinical week right now. What does that look like? What kind of volume of patients do you see, and what type of conditions are you mainly treating at the moment? Like, is there something you're more interested in that you see a lot of?
Yeah, look, my work week's pretty different in the sense that it's consistently inconsistent. So before this webinar this morning, I've treated 4 clients. I ran a Occ Health webinar for a corporate client, and now I'm coming to do this webinar. So every day is different. So typically 3 days a week, or 3 sort of 6 to 8 hour blocks, I'm treating clients in the clinic. So they're all coming in for their traditional muscle-related issues. Some of those are very much around, I suppose, optimizing health and well-being from a goals approach and that sort of stuff. And then there's obviously those more reactive clients who have pain and a particular complaint, who are requiring sort of a diagnosis, treatment and management plan in that earlier phase. So really the consultation varies. our client base in the CBD, so we're captive here in the Melbourne CBD, so it's typically anyone between, say, 20 and, say, 70, but the vast majority are probably in that sort of 30 to 50 age group. And I probably found, I'm not sure about you, Sammy, but as I've got older, my clients have got older with me. So, and so therefore, those people come along for the journey, and their needs and requirements change as we evolve with age and that sort of stuff. So the same clients I used to do lots of manual therapy for acute care and just, you know, getting them back up on the park to play sport, and now very much focused around optimizing health and well-being so that they can be fit and healthy into their older years to be able to do the things they want to do when they retire or get more spare time and that sort of stuff.
Yeah, definitely. I think you grow up with your client base too, and when you're a young practitioner, I think you tend to attract that demographic, and that's good because that demographic really grows your practice. You know, you have families on board, younger kids. You know, you see the footy teams, and then you see the other parents from the other kids. You know, the footy teams, and it grows that way. With regards to your OH&S, the Occupational Health and Safety side of your career, how much time does that consume for you on a weekly basis? And tell us about that. What made you segue down that path?
Yeah, look, so at current, I have two businesses. One's the clinical practice, probably 45% of my time. Then I have the Occ Health and Safety or Occupational Health business, 45% of my time, and then the other 10% of my time spent like teaching and in that sort of post-grad education space and at university. I got into that when I first moved to the UK. So I arrived there in March 2006 and couldn't sit my exam to work as an osteopath till July. So I had 3 to 4 months of spare time that I needed to fill and make some money. So I got in contact with an organisation called Osteopaths for Industry. And so that was set up by Janice Kay, who is probably now a 35-year sort of graduated osteopath. And she pretty much had an organisation that did they pretty much offered what our compensation system here does for early intervention treatment stuff, but they also worked in the space of Occ Health and Safety, which was in workplace ergonomics and manual handling. And so I started working for her in that process and started getting exposure then, because that was obviously not covered at all and wasn't really our domain at all in Australia at that point in time. And so went down that pathway, and that was on the back end of, say, two other osteopaths, say Grant Burrows, who's another Melbourne trained osteopath, and Steve Lee, who had pioneered as Australians working for her over there. So I got that opportunity off the back end of them. And then sat the exam to be an osteopath. So then I went into teaching, private clinic practice, and then effectively OH&S. So I'm a person that probably gets a little bit bored just doing the one thing the whole time, and I like to be juggling lots of things in the air. And so that sort of gave me the concept and the idea, well, to me, being an osteopath is a way of thinking. I'm just applying the process and the thoughts and the principles and philosophy, and what's changing there is often the context. And so you're applying the same sort of thought process as you would with a patient in a clinical setting, but you're just now doing it within a work environment. You're doing a case history, you're doing an assessment, you're doing an intervention. It's all the same process, it's just the context is different. So that's sort of how that evolved. And then upon returning around 2009, I started up that the business here with my business partner, Wade Brennan, who's a physio, who I worked with over there in the later phases of my sort of working with Osteopaths for Industry over there.
Yeah, right. That's very interesting. I want to give you a little bit of, I want to tell you, go through a little story of mine and get your input on it. Back in about 2010, one of my friends, she was the CEO of the Deaf Society of Australia, and we got to know each other through just networking. And she asked me, she knew I was an osteopath, and she came to see me for treatment. And then she was telling me that there was a lot of people at her work that were getting some issues with, you know, just office type strains and aches and patterns. And she asked if I could do a ergonomics assessment on her workplace. Now, they had about 60 employees over in their office. And so I kind of sat there and I had to think about it. And I thought, well, why couldn't I do that? Like, you know, I would just apply my thought process the same as I would do in the clinic and just take it to someone's workplace and say, this looks good, this doesn't look good. But what I did do is I systemized it a little bit more. I downloaded the work cover recommendations from New South Wales and looked at some of their recommendations. I downloaded some of the ergonomic assessment forms that they had, and I compiled my own little checklist of things to look for. And then what I did is I spoke to the management. I spoke to her and asked her if there was anyone in particular that that was complaining, that was more specifically complaining of pain. And so we honed it down to where there was, I think, about 45 or 47 employees that were pretty good, but there was about maybe 12 to 15 employees that were kind of complaining about things, and we had to do a bit more of a thorough assessment. So I went down there and we picked out those 12 employees, and it took me roughly, I think, about 4 full days to fully assess the employees that needed some attention, and then obviously the workstations of the ones that didn't need that much close attention. And so we assessed them, I assessed them, I used the checklist, and the ones that needed some closer attention, I actually went through a case history with them. And then I made my recommendations as to what they needed, and then we gave them all the data, and we gave them all the actual recommendations of how they could change, what kind of chairs they could purchase, the desk heights, and whether someone required a standing desk or a sit-stand desk or whatever. We did all that, and I think we ended up invoicing each person at about, from memory, back then it was about $80 or $90 per consult, and about $120 per individualized case. And so there was a bit of there was good income behind that. And I really never had a background in OH&S, but I just used my own. It's like you get asked questions by patients all the time about what to do at work, and you give them answers when you're in the clinic. And so why can't you give them answers at their own work? And so I just used that philosophy and kind of did that. Would that be along the lines of what you would kind of do and recommend?
Pretty much, to be honest with you. So as you've gone through, you've applied a risk management process. You've identified of the total number who has issues, who doesn't. So therefore, it's going to change the scope of work. You've come up with the template, which is excellent. So we want to systemize the process in terms of the consult process. You'll obviously, for those that have issues, you'll do your case history, your assessment. We're not necessarily doing, as you say, an orthopedic assessment. You're assessing how that person interacts with their equipment, and obviously.
We took photos and some videos and things like that. Yeah,
spot on. And then obviously I suppose your control measures or your treatment and management interventions might be physical changes. It might be, I suppose, movement breaks and behaviours, so how that person does that stuff. And then obviously there might be some I suppose there might be some other factors at play that could be feeding into that person. Following the biopsychosocial model, there could be some other contributing stresses there for that, which we can, I suppose, one-on-one have a bit of a chat about. So that's perfect, what you've gone through.
Yeah, well, and that's just the reason why I'm highlighting that, I think, for the listeners, is that osteopathy is really it's a philosophy, it's a thought process, and it's a principles in practice, and you can put those principles in practice in any way you like. And this is the advantage of it. It's not recipes. We don't hand out recipes. And our thought process has to be adaptable, and I think that's one of the great strengths of what we do. And one more important question about that, just to follow up: did I charge enough money?
Well, firstly, I don't know how long you spent with them, mate. So, if your hourly rate was
it took me about 4 days, 4 full 8-hour days.
Well, I would hope that your hourly rate probably somewhat aligned to what your hourly rate is now.
Well, I didn't even think about it that way. I charge per person.
Yeah. Well, I think per person's a dangerous place to dabble in. If you get it wrong, you could be earning $1 an hour.
Well, there you go. See, great lesson. We did something, like I said, it was about $80 or $90 per person. There was about 45 at that rate, and there was about another 12 to 15 at about 120. So, no, I was happy with the outcome for 4 days worth of work. It was pretty good.
Totally, and it's definitely a. So I always chat to some people that are osteopaths are very comfortable spending time one-on-one in a treatment room, very much touch manual therapy approach. And then and what I suppose this is just experience again, seeing the cohorts of students coming through. There's probably a group of practitioners that are graduating that are probably less inclined to want to be in a room, one-on-one manual therapy. And so they're like, well, what do I do now? And so I'm always like, well, how about we use those skills, which make up 95% of your stuff. The hands-on stuff is a technique and a strategy that you can adopt. And why don't we just apply that to another context? And therefore, you're not sort of necessarily wasting your 5 years of study. And we see that and it's a growth here in Victoria anyway. It's definitely a growth area for employment for osteopaths.
Do you advise somebody? I mean, to kind of follow up on that, then let's go down there. Would you advise somebody to at least get some practice skills under their belt before they go down the path of, or is it something where they can do straight out of university? I mean, like, you've been in it for a while.
Yeah.
And you're good at what you do, and I'm assuming that part of what makes you good at what you do is that you take the skills you've learned in practice and you just apply them. I know the thought process is there, but if you had to advise somebody, if you had a student you were mentoring, would you say, look, get a couple of years under your belt, learning how to manage patients, learning how to manage people, learning how to communicate, learning how to, I mean, a basic treatment plan for an acute condition should be something that you should be able to do with good competency before you kind of move on to try to manage some larger projects in terms of OH&S. Would that be good advice?
Yeah, definitely. I probably, and again, I'll preface it with saying it probably depends on what space you're going to work within that broader health and safety space. So if you're going to work in the preventative education, sort of service offering space, you could probably step out and do it quite straight away. But if you're going to work in the rehab, return to work, I suppose, case manager within the compensation system, then you want to know and have a feel for, having worked with compensation-based clients, you need to understand the challenges they have. You need to obviously understand the prognosis for those conditions and all the factors that feed into it. I think everyone can get there. It'll just be, I suppose, what's that path like to get to that endpoint? So it might be a new grad straight into rehab, new grad into clinical practice. If you look at them both at 5 years, they're probably both there. It's just obviously that maybe the person who's done clinical practice for 3 years and then could fast track within 2 years to get to the same point. It probably is probably that approach.
Right. Okay. I get that. That's a great answer to that. You mentioned earlier your business partner. He's a physiotherapist.
Yep.
What's it been like collaborating with him on projects, and what's that been like in business? I mean, you're Principle Four Osteopathy, and you have a physiotherapist as a business partner. Has that been something that's obviously it's been something that's helped you because you're still there, you're still partners. What's it been like working with him?
I would say it's been easy. So I suppose we have our own independent clinical practices that are separate, and then we come together to collaborate on this joint business. So therefore, we get the benefits of both worlds. We have the different thought processes and experiences. So he's got strengths in, I suppose, certain areas that we didn't have necessarily strengths in, and that sort of probably comes back to the undergraduate sort of learnings and that sort of stuff. And then same thing for us, we bring different strengths. And I'm always about, well, how do we collaborate and tap into people's strengths, and how do we prop other people up where there's weaknesses to increase your learning opportunity there? So to me, it's easy. So like I've got a range of mates that are all different allied health practitioners, and often obviously as osteopaths, we can be quite unique and distinct in what we are, but I also think it's a person's approach and philosophy around learning. Are they curious? Are they seeking out opportunity? I want to sort of collaborate with those people regardless of obviously what profession they are, because they're the people we're going to go on I suppose a learning process and journey and be able to work with and that sort of stuff.
Yeah. You're looking for that growth mindset.
Very much so.
Yeah, understandable. Look, you've attended many courses that aim to understand human movement. Specifically from a rehab perspective as well. How do you feel rehab should be taught in light of osteopathic thought and philosophy to our graduates? So I still don't know if there is a systemized or at least a unified approach to how osteopaths view rehabilitation, because a barbell, a dumbbell, or whatever you want to call it, a squat rack, whatever it is, that's another tool in our toolbox. And so again, the thought process still has to be the thing that defines us. And so in light of that thought process, how do you think rehabilitation should be taught to osteopaths?
That's it. That is the $1 million question.
It's a loaded question because there's a lot going on there. I mean, like you see some osteopaths going down the road to clinical Pilates, other osteopaths go down the S&C route. Yep. Other osteopaths will just do some yoga or something, or
correct.
And then other people will maybe not do much at all.
And they're all modalities, aren't they? So
they are. Yeah.
So
we have to teach our students something, right? And what do we teach them?
Correct. So I actually don't know what they're necessarily taught directly now, but obviously, I suppose we need to, understanding the human body from a biomechanical, physiological point of view, and understanding, I suppose, clinical diagnosis and tissue healing times, and looking at sort of that area, but as a holistic approach, looking at it as a whole biomechanically, but then also considering the broader systems around that. I suppose you could pretty much come back to teaching just general principles, I suppose. And then the problem is if you say apply the principles that you know to so, the challenge with rehab, I think, is that then unless you're shown a modality and understand a whole gamut of things that make up that modality, it's hard to, I suppose, adapt those activities or exercises to that person if you actually don't know that. And that's where things get tricky, I think. You've got like your early phase of rehab, which focuses on mobilization, then into obviously your retain range of motion, build strength and endurance, like that approach to stuff, which is fine. But then obviously, if you just say to somebody, well, I want you to do that, then I also think somehow people don't necessarily know what to do because they haven't been shown what to do.
Yeah.
And the challenge is obviously with universities, no doubt, will be the fact that we're taking more and more out of courses. So therefore, there's less and less of the technique stuff that's being shown because we're having to prioritize other stuff. And so therefore, people may have less tools in the toolbox at graduation. So therefore, at graduation phase, really, you've got to pursue areas of interest to be able to learn what those tools are, to have it in your toolbox, to then apply, obviously, your philosophy and your principles utilizing those different tools or strategies. I think that's the tricky thing. Because we do lots of, I suppose, body weight and traditional conventional gym S&C stuff in our clinic. We've got a full studio thing there. However, the people that come to our clinic are already got an interest in that. Typically, we've got a very select type of client that comes there for that. However, the person still needs to be adaptable and adapted to the person's goals and their objectives. And so if that so-and-so person doesn't want to do any of that stuff because it doesn't really land with their interest and they're not internally motivated to do it, then we have to be adaptable to prescribe stuff that's going to help them on that journey. And it might be that we can prescribe just general movement, general mobility and flexibility stuff, general sleep, general nutritional advice, all this sort of stuff falls within the broader component of that person's rehab and management of their condition. But then you also then need to go, well, okay, I've pretty much hit the wall with what my capabilities are that's suitable to you. So now I need you to maybe go off and explore these things with other people that might be more focused around that person's goal. So that's sort of, I've sort of talked around in circles there a little bit. I think from a rehab perspective, I'm not quite sure what's taught up at RMIT, and I'm not sure what's taught at SCU and that sort of stuff. And what I know here in VU is that'll be taught within a block model. And when you're allocated, say, hypothetically, this is just a number I'm throwing out there, you've got 10 hours to apply some type of rehab knowledge to the osteopathic student. It probably needs to be very high level stuff in order for that person just to get a grasp on it. And so that when they graduate, they can at least go, well, okay, I know where to look in order to go and further learn if I want to obviously focus on that as part of my treatment approach. The problem with that is obviously we start now creating specializations rather than obviously having the general osteopath be able to broadly do everything. And so that's probably where we have a little bit of a disconnect between osteopathy can be a bit of everything for everyone, but then you've also got this ability to have specialization. So it can be a little bit tricky.
Yeah, I guess. All right. Well, let me try to kind of flesh out what you just discussed there. So first of all, you mentioned how there's obviously been some challenges in terms of taking things out from a technique point of view, from a toolbox point of view, out of the courses to make way for things that need to be in there. Now, that begs the question. I mean, what are they taking out and what are they putting it in? What are they putting in and what's the justification? But that's a whole nother debate. But then you use that point to say that, well, then it gives limited opportunity for us to have any real osteopathic-based rehabilitation protocol that we teach our students. And so what that causes is people to have to go out and do their own little post-grad little bits and pieces, and it allows for people to be more specialized rather than having an overall osteopathic framework to rehabilitation. Would that summarize what you just talked about?
Yeah, somewhat. Yep, very much so.
Yeah. So the reason why I'm asking you this question is because you have a background in human movement. You've kind of studied what's out there. You've seen all the courses that's out there. You know, there's a whole bunch of different stuff, and I guess I've always applied my own osteopathic philosophy on rehabilitation. I base what I do with patients. There's three movements that I still can't get past, and those movements are the squat, the deadlift, and the overhead press. And
Yep.
I haven't found a condition yet that those three movements cannot address. And yet, every time I talk to a practitioner that's either not an osteopath or an osteopath that doesn't maybe think at the rehab process in that light, you know, I don't know why you would give a hamstring curl to a hamstring injury as opposed to a deadlift. And so that's a philosophical question. I understand there's physiological reasons, but you're getting the same physiological response out of a deadlift as you are out of a hamstring curl. And it actually makes sense in terms of osteopathic light, holistic approach to the body, structure, function, and then respecting the tissue healing process as well.
Yep.
And so we're leaving it to our students to go out and do a lot of these courses that are teaching them to really segmentalize the body, whereas osteopathic philosophy is telling you to take the whole chain, the whole pattern into account. So I wanted to just bounce that off you for a minute, you know, and how you feel about that, and if there's things that you agree with there, and if there's things that you don't agree with there, you want to push back on that, I'm happy to discuss that with you.
Hello everyone, just a quick break to give you some information on where to best find me. The first place is the private Facebook group called the Successful Practitioner Pathway. I've set up this private group as a place where practitioners can go and get tips and advice on how to best accelerate their practice and improve their clinical practice skills. The second place to find me is at successinpractice.net. That is where the Success in Practice signature program is housed. You can find more information about me and how I can best help you achieve success in your practice. So the two best places, the private Facebook group, the Successful Practitioner Pathway, and successinpractice.net. I will link to both those places in the show notes. So for more information, please see the show notes. Now, enjoy, and back to the show.
No, totally. So I suppose if you identify what we as humans do, so we move in 3 dimensions. So we need to consider that in our exercise approach. So not just a vertical or sagittal plane movement, which traditionally you'll see in a lot of S&C programs. It's how fast can you go forward? How high can you jump? What's the movement like and that stuff? So that's sort of where I think we need to apply a 3-dimensional approach to exercise prescription. But then, and again, if I'm paraphrasing you wrong, let me know. But effectively, you pick 3 fundamental movements. So if we think about what we do, we squat, we hinge. You have to be able to do some single leg balance work. You have to be able to like lunge or step. You have to be able to rotate, brace, push, pull, arc patterns and this sort of stuff. So when I think about a person and what they're needing to do, like just broadly speaking to live, I'd probably try to prescribe a lot of stuff around those patterns of movement as you've sort of described, because if we're thinking about, well, so-and-so's got limited time, maybe they're a little bit motivated, what's going to create change, what's going to give me best value for money, then I'm going to chase that stuff. And then it'll just be a derivative of those.
Yeah.
According to where that person is at that point in time with their complaint and perhaps their physical literacy and learning history and this stuff and what their tissues are going to be able to deal with. And then so therefore then it's, well, okay, let's either move towards that or let's back it off and then let's get you back to that sort of stuff.
Yeah. Well, also you mentioned earlier about you know, when you kind of, you've done what you can, you've hit a brick wall, and maybe you know, refer off or ask for them to see someone else. I think in that sense also you got to understand, like you said it really well, and you said you're trying to give them the best bang for their buck, and those movements, those primal movements, offer the best bang for buck in terms of trying to utilize the maximum amount of muscle mass in one movement, the maximum effective range of motion. And the good thing about them is that they can be incrementally increased in terms of resistance. And so you can build strength with them really, really well. And understanding those principles, I think, really aligns with osteopathic philosophy. What I'm also getting pushback on is that, well, you know, I've got a 66-year-old, you know, female who's a grandmother and she doesn't want a deadlift. And I'm like, well, look, I've got a couple of 70-year-old women here who have reversed osteoporosis through squats and deadlifts. I think we need to also give credit to our patients. I think they, you know, like you might see some people and go, well, they can't do that, but they can. You know, they everybody can. It's just, it's up to you to kind of drive that process. And I talk to this to my students about it. And I'll say, yes, medicine is patient-centered, but it's also practitioner-driven. You know, you're somebody that needs to show people the light at the end of the tunnel, and your ability to do that will largely be, it'll determine your talent. You know, how talented you are.
Yep, definitely. You know? And I suppose when somebody's not wanting to or willing to prescribe that stuff, is that because they don't have the knowledge or expertise in that, or they perhaps have a fear around what could happen versus like going on that journey of trying to explore that? Obviously, it's all around risk management and that.
There would be a whole range of issues, and you're making great points there. But, you know, they all have to be addressed with education. Ultimately, we're leaving it up to the students to find their own postgraduate things to do. But I think there's a real gap there for us as osteopaths in terms of tertiary education and maybe at least giving people what the framework should look like as rehabilitation for osteopathy. Now, you may not agree with that, and you might then want to go and do something else afterwards. I mean, we received clinical Pilates as our, or not even clinical Pilates, just Pilates as our 6-month rehabilitation when I was at university. And I thought, geez, now looking back on it, I'm like, you know, what a sorry, but, you know, like, what a waste of 6 months. I could have been doing something that, you know, I could apply to all my patients rather than just a subsection. Now, I'm not having a go there at people that do clinical Pilates, but as a student, I would have liked to get more value out of that. But that's another conversation. This is something we could discuss, me and you, I think, for a little while. So we might leave that maybe for round 2, maybe another time. I want to move on and talk about you're titled by Osteopathy Australia as an occupational health osteopath. Tell us about that process, and if were you involved in kind of setting that all up, and what's that been like for you?
Yeah, definitely. So, so I've been involved with it since the start of its idea and conception. So, probably 7-8 years ago now, Osteopathy Australia wanted to start exploring the ability to have advanced practice opportunities for learning for practitioners, just to sort of obviously show, I suppose, give practitioners an opportunity to look at alternative career pathways, or at least have areas to focus in, because already we have lots of osteopaths with different specialties, I suppose, or expertise in certain areas.
So you were approached, sorry to cut you off, but you were approached about 7 or 8 years ago, is that correct, to kind of set this up?
I remember they started the advanced clinical practice committees, and I had the opportunity. I applied to sit on the occupational health and safety one. And at the start of that, they created pain, peds, sports, rehab. These were the 5 sort of key ones.
And who was it? Who initiated that? So was that the executive that approached you? Was it the board members? Was it?
From memory, it was put out through OA to apply if you were interested in that area.
Right.
And then obviously put an application in to sit on the committee, and then obviously start the process of trying to build a framework around how we can actually set this up. Right. So that took sort of a good 4 or 5 years. Peter Lally was like one of the primary drivers of that. Yep.
Yeah.
And he did an amazing job sort of getting that to where it was. And obviously after many years and back and forth and this sort of stuff, they finally sort of established, I suppose, the criteria, the framework, and the application process, which is now sort of obviously been going probably 3 or 4 years or so now. And you've got 2 pathways of applying. You've got your postgraduate application pathway. So if you've done, say, a postgrad in ergonomics or a master's in OH&S, you can go that pathway, or you've got your vocational pathway, which is obviously, show us all your PD learnings, put together case studies and examples, and that will be assessed by an external person that's not necessarily an osteopath against those criteria to be obviously given that sort of titling if deemed appropriate.
Okay, and given the way that it's set up now, is that something that's helped you in terms of recognition? You personally, I mean, you've been doing OHS for a little while now, and I'm assuming being in business as well, you understand that you've probably been marketing yourself in that space already.
Yep.
Have people been specifically saying, well, hey, you're an occupational health and safety osteopath, we'd like you to come in, or were they doing that anyway before you had the title?
I think things like titles and that stuff probably just help validate the process. And this is, again, just speaking from my experience. You've got all the like who you are is an accumulation of everything, and that's just one point that can help validate that. I wouldn't say that I've won any particular work off the back of that, but it's probably also helped achieve some other work. Just like any type of, like I've done I'm a member of the Strength and Conditioning Association, done level 1, level 2. That, like, having that stuff there just helps obviously validate that process and that person and their, I suppose, their experience and their knowledge and this sort of stuff. So it might just help in the decision-making process, because effectively we're all selling something, aren't we? You're selling something, I'm selling something, and effectively, as part of that process, obviously, we need to have lots of things that will help that person make a decision between them or them. And I reckon that sort of probably helps a little bit in that space. What I would say, sort of speaking to the this particular committee group and what that has done, off the back end of that, having set up that OH&S committee group and having that advanced pathway and then working with a few key individuals within OA, that has pretty much opened up the opportunity for osteopaths to be able to work in op rehab here in Victoria, which is massive. That was previously kept away from us and was available to physios, EPs. Osteopaths never had a chance. So in that process of application, that's enabled us to then apply to get access and equal footing with the other allied health practitioners and that sort of stuff. So that's where that has been a real driver for change. And obviously you're in New South Wales, so I think that works under the CIRA program, and there's slightly differences there. And I think you can work in op rehab if you've been a graduate post a certain time frame, because they could demonstrate that those osteopaths had covered off on the inherent requirements of that. And it might be like a 2010 number. I don't know what number that is. And anyone predating that, obviously, we haven't yet gone through that process of demonstrating that. Yeah.
I was actually one of the first people to get a CIRA number in New South Wales. It's an odd one. I remember actually going to one of the first ever CIRA workshops where you had the old work cover numbers. And then what they did, they changed the system here in New South Wales, and we had to go to do a workshop, and it was me and another osteopath that went. And we turned up to this workshop, and we were the only two people there. And the guy was there, and he was packing up. I'm like, well, there's a workshop here, mate. What's going on? And he's like, oh, you guys are the only ones here. Well, we're just going to shut down shop and go home.
Yeah, right.
Well, we've paid for it, and we've signed up. We actually didn't have to pay for it, sorry, but they go, we've signed up, and we're here to do it. He goes, well, look, I'll tick your names off and give you the numbers, and they're just going to be provisional numbers until you do the next one. Mate, I've had that provisional number work for me ever since that day. I don't do a lot of work cover stuff anymore, just out of choice. But yeah, that was, you're right. That was around the 2010 mark that happened. And it was just an interesting story. I want to ask you about your time with Osteopathy Australia has been largely to do with the Advanced Practice Committee and also the Education Committee in terms of continuing education. Has that been something that you've enjoyed in terms of giving back to the profession and just working with that organisation? Have you found it kind of a good place in terms of effectuating change within your profession?
Look, I'm a big believer in supporting the organisation that represents most osteopaths, and without Osteo Australia, there's probably a lot of things that we wouldn't have right now. So I wholeheartedly try and support that as much as I can. And I suppose I put my hand up for those committees because it's all voluntary, because I have an area of interest in that space. And essentially, as just one of many that are also volunteering, I suppose our goal is to raise the bar, raise the offerings, raise the service. Obviously, like with any organisation, especially a small one, and where you've got largely a volunteer base, things take time to change. And definitely I've experienced that. And obviously, like anyone, there'll be elements of frustration for lack of change over time and that sort of stuff. But ultimately, I could have either cracked it and given up, or I'm going to stick my hand up and say, I'm going to be someone to try and make change. Yeah. And so hence I've stuck with those things, and I'm going to continue until I maybe can't for some other reason, or move on to other stuff. But definitely it's been a enjoyable sort of process. And I suppose I'm always a believer in, well, if you want change to occur, then you need to be part of that process to help change occur.
Yeah.
And obviously we're in a pretty vocal profession. And again, this is all based on stuff that you might read online, and there's lots of opinions, and there's a vast array of opinions. Yeah. And there's obviously been a lot of people that contribute voluntarily over time and that sort of stuff, which is amazing, because we wouldn't be where we are and you are and that sort of stuff without that stuff. But obviously there needs to be often at times some of that robust debate and conflict to create change.
Yeah, definitely.
And so I'm a big believer in obviously having that forum where you can have opinions and not get shut down, and have a debate about that stuff to be able to create change moving forward. Otherwise all we do is become one and the same.
Yeah, this is largely also the motivation for this platform, is that I think we want to talk to people who don't share similar viewpoints, but I think we all have to have our heart in the right place, and differing opinions is exactly what you want. You want diversity in opinion, I think, and diversity in thought, and so that hopefully the competition of ideas is the marketplace where you want to get the best ideas. That's where it's at. And so what I want to ask you then is now, given your experience with what you've been doing, maybe opening up a new horizon there in the OH&S space, and with your work with Osteopathy Australia, and what you've been doing in private practice and your travels and everything we've discussed today, what do you feel like are some of the opportunities ahead for us in the next 20 years? What are some of the challenges? Where do you think are we getting stuck somewhere? And then what do you see some of the opportunities?
Yeah, look, I suppose if I go back to like when I lived in the UK, and the thinking about what an osteopath was and how they could practice and this sort of stuff, they had diversity. And I think probably we're probably sort of seeing hopefully we're seeing more diverse practice here in Australia. And that sort of stuff. But I also think So diverse in terms of like other opportunities to use your expertise. But when I think about, say, coming back to the core of what an osteopath originally was, which is a private practice manual therapist, I think we're probably losing the essence of that a little bit. And I think looking at sort of that in its own right is going to become its own specialty pretty soon, if it isn't already. Whereas it used to be 90% of osteopaths were, or 100% were like osteopaths with strong manual therapy skills, and you could go see generally any osteopath and you'd probably get a good outcome. And I think nowadays we're probably seeing less and less of that. And the core crux of a good manual therapist is probably dropping off.
Why do you think that is?
Look, it could be because a number of reasons. It might be, and I'm just going to throw some ideas out there, but it could be that if we think about, I suppose, what's being taught at university level, if there's less of that, then you get less exposure. The people that teach that content, maybe we've got less people with that experience teaching that who have found success in that. So therefore, them as role models and people to look up to maybe drops off a bit. Then you've got a bunch of practitioners that maybe don't even have an interest in being a manual therapist. They've done osteopathy, but they actually don't want to do that anymore. So therefore, they're moving into other spaces. And I suppose, unfortunately, I caught up with an osteopath yesterday. He's a student and he's about to graduate. And I'm not going to say his name, but in chatting to him, and we were having a bit of a mentoring session effectively. And he's like, a lot of people I've chatted to have gone into osteopathy, working in private practice, and they haven't really ever had the love for osteopathy or been shown how good osteopathy can be, and to have the passion and see someone who has the passion and the motivation and the success and see how it's done well. So therefore, if you don't get to see that, then effectively, how do you ever have something to aspire to become that? And I think that's probably where we're going to see a bit of that stuff go on in the manual therapy space. And hence where, I suppose, if you're going to be exclusively just a really good manual therapist, I think that's going to be its own specialty.
Yeah, I guess, sorry to cut you off, but I guess, you know, if you don't see the best of your partner, it's really hard to fall in love with them. And it's the same with the profession, you know. If you don't see the best of the profession, if you're not close to that, it's really hard to fall in love with what you do.
Definitely. Definitely. But where it could be going is obviously the fact that you've got sort of different areas there. You've got a lot more, I suppose, employment opportunities where you could have someone who's graduated as an osteopath, holds the title as an osteopath. And so I often get torn around this idea of, well, is an osteopath is a person, is a way of thinking, is an approach. And we don't want to just pigeonhole them in a private practice setting. We also, it's how does that person apply that to whatever environment they want to focus on? And let's also celebrate those successes, whether it's op rehab, S&C, performance, like Gen Pop in the private practice setting, whatever it is. So I do see there being lots of growth factors in that way. The challenge will probably be, if we step outside the internal profession, it's like, well, okay, so there's us, there's chiros, there's physios, there's EPs. You've got all these allied health people all working and learning within the BPS model. We're all often having to work under the APRA system, except the OCS is under their own and that sort of stuff. And so therefore, I suppose sometimes are we losing our identity in that at times? And I think that's also a bit of a challenge at the moment.
Yeah, definitely. I think they're all great points that you've made. I would probably add to that, and it may not be directly in line with what you were saying, but I really feel that at the very least, whether you work in private practice or you at least get to observe private practice, it really is a great place to see it happen right in front of your eyes. You know, see osteopathy really play out, and it's where you really appreciate it and love it. And then, you know, if you want to go and take that and do what you want with it, like you said, I think that's fantastic. I think opening up into new places, new horizons is great. But you know, I don't like a place where an osteopathic, either a student or a new grad, can go to a private practice and go, you know what, this is not for me. So I think if that is happening, I think it's to our shame. I think we need to make that a better experience for students, for graduates, for people who are doing clinical placement. We need to show them the best of that, and then if they say, look, this is great, but I want to do X, Y, Z, then that's something that obviously should be celebrated. All right, well, I think that's a great place to let you go for our public listeners, Heath. You've given us some great insight, mate. And I really appreciate you taking the time. What I will do is continue this conversation with Heath on the other side for the Success in Practice students. Heath, before I let you go, mate, where can people get a hold of you in case they want to either social media or website or email, something like that?
Yep, no worries. So the best place would be to email, which is heath.williams@principle4.com. And that's PRINCIPLE 4.com. Otherwise, you can check out Principle Four Osteopathy on the webpage or Corporate Health Australia and have a look at those two businesses. Contact me if you have any questions.
Great. Thank you, Heath.